Hello, and welcome to today's training, Who Should I Treat? Specialization versus Generalization in Clinical Practice with Andrea J. Baton, LCPC, with Denise Egan-Stack, LMHC, and John Hirschfield, MFT. This professional webinar is a collaboration with the Early Career Professionals and Students Special Interest Group. Welcome. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. We will first kindly ask you to mute yourselves so that we don't hear any background noise. To mute yourself, you will need to press the gray tab just below the red arrow. Kindly also switch off your webcam. The webcam tab is just below the mute tab. You will have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. You will also be able to access materials. I would now like to introduce our panel experts. Andrea Baton, LCPC, is a licensed therapist and supervisor in Maryland and director of the Maryland Anxiety Center. She is active on the board of Mid-Atlantic OCD, the regional affiliate of the International OCD Foundation Council. She received the Early Researcher Award from the Ministry of Research and Innovation. Denise Egan-Stack, LMHC, is a home-based behavioral therapist in Massachusetts, specializing in the treatment of OCD and related disorders. Denise was involved with the development and launch of the OCD Institute at McLean Hospital in 1997 and has served on the IOCDF Board of Directors since 2017, during which she served 2 terms as president. And John Hirschfield, MFT, is a psychotherapist in private practice, licensed in Maryland, Virginia, and California, and director of the OCD and Anxiety Center of Greater Baltimore. It is a true honor and pleasure to work with these professionals. We will now start discussing questions with our professionals as they relate to the webinar topic. Who should I treat? Specialization versus generalization in clinical practice. The goals of today's webinar are twofold. First, one goal is to build awareness and increase education regarding the importance of specializing as a mental health clinician, and secondly, to encourage and inspire therapists to specialize in treating people suffering from anxiety, depression, and related disorders, such as OCD. We hope that at the end of the webinar, you will have gained understanding about the importance of clinical competency, the difference in patient outcomes between treatment from a generalist and a specialist, what makes someone an expert, and the steps to take to become an expert on depression and related disorders. For whom is this presentation appropriate? This presentation is appropriate for mental health clinicians who are not currently specializing. Graduate students, professors of students studying psychology, mental health counseling, and social work, and also advisors, supervisors of students, and/or new clinicians in psychology, mental health counseling, and social work. And now let us begin with the questions. Denise, John, and Andrea, what has inspired you to specialize in treating anxiety, depression, and related disorders? What was your path towards becoming an expert?
I'll answer first. So when I was in graduate school, I was studying cognitive behavioral theory, and that was a theory that really made sense to me. It's sort of how my brain worked or the way that I related to the world in general. And so when it came time to find a practicum and internship site, I really wanted to find an opportunity that would allow me to be able to practice cognitive behavioral therapy in a clinical setting. And I ended up at McLean Hospital in Belmont, Massachusetts, doing home-based behavioral therapy for people with anxiety and OCD. And as we all know, CBT is a very effective treatment for anxiety disorder. So the people that I was seeing were getting better. They were getting better pretty quickly, and I was really enjoying my experience working with them. And at the same time, this was in the mid 1990s, even though I was working in Boston, which is considered a medical mecca, there were very few people that were doing this. And so not only was it something that I really liked to do, it was also an area of need that I could help to fill. So I sort of decided pretty early on in my career that this is what I wanted to do. I wanted to specialize in treating anxiety and OCD using cognitive behavioral therapy. I do want to just note, though, that at that time I had already had a few years of more general clinical experience. I did 2-year-long internships in undergrad and 2-year-long internships in grad school. So I had conducted research, I'd worked in a state mental health facility, I'd worked in mental health, a community mental health center, in a residential treatment for teens, residential treatment program for teens. So by the time I had sort of decided to specialize, I already had about 4 or 5 years of more general experience, which I think helped me sort of understand as a specialist where my place would be in the field in general, which was very helpful. And I think that those 4 or 5 years of very general experience really I've benefited tremendously from that through the course of the last 20 years that I've been doing this job. So while I'm advocating for specializing, at the same time I'm sort of advocating that people get some general experience beforehand. At least that's been my path, and that's what's been helpful to me.
So I'll pick up with my story. Let's see. So about 13 years ago, I was an unemployed actor living in Los Angeles, careening towards a mental health crisis, which finally arrived, which put me into therapy for my OCD. And it was the first time, so I was about 28 years old. It was the first time that I, having lived with OCD my whole life, it was the first time that I'd actually taken the therapy part of it seriously and really worked the tools that I was learning and noticed that I was actually getting better. And at that same time, I started contributing to online support groups, both asking for advice and giving advice. And I found that I got a lot out of corresponding with people online with OCD, both describing my experience with CBT and how it was helped me to internalize the concepts, but also it was, gave me an opportunity to start helping other people. Asking, maybe you should look at it like this, or here's what, my therapist might recommend that I do, maybe it work for you, that sort of thing. And I started doing a lot of it. Then I started running the group, and the group is actually still alive today, and has a few thousand members. And this is an email-based Yahoo discussion board, which sounds really dated now. But and as I continued to get better, and as I was noticing, and the people I cared about, the people around me were noticing that I was really getting a charge out of interacting with people on this level, people started recommending to me, hey, you should become a therapist. You should, that suits you better than being unemployed. And I had one thing I had learned in therapy was that it sometimes works out in my best interest when I take the advice of others over what happens to be going on in my head. So I took the leap. And decided to go to graduate school, where I was actually pretty ambivalent about it. I was really afraid to leave my old profession and to try something new. On the other hand, I knew I really was passionate about what I wanted to do, and I wanted to help people with OCD. And day one of my first class, I knew that I was at home, that this is really where I belonged. And the interesting thing, though, was I was going for a marriage and family therapy license, which is sort of a popular thing to do if you're going to enter the psychology world at a master's level in California. And there was only one class in CBT, which was an elective. And there wasn't really any information about OCD, and certainly no information about how to use CBT to treat OCD. So I had to kind of think about that and to sort of get through the process of graduate school and try to make every paper that I wrote somehow be about OCD and create opportunities for myself to learn more about CBT and OCD. And at some point, I actually invented my own class called OCD, and I got a professor to sign off on it, and which basically just meant I went to the International OCD Foundation conference that year and wrote a paper about it. And I was just very fortunate that after my initial practicum at a youth center in South Central, working with kids, I landed a position as a MFT intern at the OCD Center of Los Angeles, which is a place that only treats OCD and related disorders. And so that's all I did for the following several years. And then after that, I went to work at UCLA in their intensive outpatient program, their pediatric program, for about a year and a half. And then I went off on my own. And then since then, about 3 years ago, I moved back to the Baltimore area where I'm from, started my own clinic here, and I love it. And I'm just really, really grateful that I made the choices that I made when I made them.
Well, I'm glad you made the choices as well. I'm also in Baltimore. My path is kind of in between. I had already in my other lifetime, I was a paralegal, and I had a master's in legal and ethical studies, and then I had my second child, and I had planned to go to law school, and realized that I really didn't care about the legal issues of the clients that we were working with, and saw them get psychological advice, really bad psychological advice, from people who were not qualified. And I felt more of an alliance with the client, the legal client. And when I had my second child, I decided that my undergraduate was law and psychology. So I decided to pursue that. And also raising my own children, I saw, a lot of emetophobia, a lot of kids spending the night and having, separation anxiety, having gastritis, and afraid that they were going to vomit, or and then some of those kids ended up refusing school. And so I saw it in the school system because I stayed at home and went back to grad school, and saw such a need that the kids for specialized treatment and anxiety related disorders, because the kids were not getting better, and they were actually getting worse and refusing school and getting mislabeled as resistant, oppositional, which wasn't the case at all. So that was a big motivator for me, as well as the people that I worked with. Also, anxiety disorders are so prevalent. I think they're the most prevalent class of psychiatric disorders. So, and they're very treatable. As Denise said, you see people get better. And so what I did was, I ended at that time in the 90s, there was no such thing as a licensed mental health counselor in Maryland, or a licensed professional counselor. So the only route was to get a doctoral degree, which is, very competitive, and I had kids. So I had planned to do that. And the closest, without driving to DC, there was only one place nearby that I could have applied to. And I think there were 700 applicants at that time, and they took 3. So luckily for me, the LCPC came out in 98. So while I had taken all the prerequisites to apply, and to graduate PhD program or PsyD program, and then found out that, and then they changed the law, and they came up with the LCPC. So I ended up going to Hopkins and getting licensed as a professional counselor. And I think one of the things that was very helpful for me in specializing was attending conferences. ADAA was actually the first one. I volunteered there years and years ago, probably while I was in doing my prerequisites, I think. So in the 90s, and, you really, I started to see who the experts were, follow their writings, and attending their presentations. I also got very involved with International OCD Foundation. They have a great newsletter. At the time, things weren't as technological as they are now, so everything was a hard copy in the mail, and I used to light my candles and sit around and read my IOCDF newsletter, which was OCF at the time, and then networking. And as Denise said, the general background, I think that is key. I did an internship, my graduate internship, at a community mental health clinic, where I saw everything from substance abuse to severe and chronic conditions like schizophrenia. And I think that is very important, because once you do start treating anxiety and related disorders, you will see people that come in and say, I think I have schizophrenia. Sometimes with the OCD themes, people are afraid that they're going crazy. So that was very beneficial to see all that, so that when you can differentiate once you start treating, some content of the thoughts in OCD can be a little bit bizarre. So I think that's very helpful. And then I sought out local experts. I worked at the Behavior Therapy Training Center of Greater Washington. Charlie Mansueto is the director there, and he actually created a postgraduate fellowship program. So I did that for a couple of years, and then helped another clinician start a practice, a CBT. It was called CBT Solutions of Baltimore, and helped him start that practice from the ground up. And then 4 years later, started my own practice. Felt that was on my bucket list. So I wanted to give back to the field by opening my own practice and offering lots of different, different ways to help this population.
Thank you so much for sharing about your path to specialization. Now, building upon what you were just all talking about, what opportunities can someone take advantage of to further develop a specialization in treating anxiety, depression, and related disorders, both during and after graduate school? What was the most valuable lesson you learned during your training that led you towards specialization and to become an expert? So perhaps Andrea, Denise, and John, you can add on to what you were previously saying. Thank you.
Okay, so I'll jump on because I had mentioned some of this when I talked about my background, volunteering at conferences. See if you can volunteer. Denise actually helped me one of my first times volunteering for IOCDF. It was an amazing experience because I monitored the presentations, and you get to introduce the speakers, you get to read their biographies, then you hear them present, you get to know who everyone is, and then that helps you with networking down the road. It also gives you that strong background, the CBT background, the opportunity to network. There's ADAA, there's also another organization called ABCT, Association of Behavioral and Cognitive Therapies. That's a really good one as well. Again, reading the expert material. And as John had said, in school, you can use any opportunity to, when you have a research paper or a project to do, you can always use that as an opportunity to learn more about anxiety and related disorders. There's also some specialized trainings, such as the Behavior Therapy Training Institute through International OCD Foundation. That's amazing. You can't do that one, I don't believe, until you're licensed, fully licensed, but it's amazing. And a lot of the conferences have pre-conference workshops. ADAA does as well, and there are more intensive trainings that you can register for. There's the webinars as well. And I think, as Denise, what we had talked about before, is getting that your internship in graduate school. I would highly recommend. Someone suggested to me, actually Sally Winston, that's another thing, is I did some informational interviews and contacted local experts and talked to them. And Dr. Sally Winston, she's the director of the Anxiety and Stress Disorder Institute, years and years ago suggested that I get a more diverse training background, so that when I specialized, I had seen everything. And that was the best advice. It was amazing. So, and then I started to specialize in network and contacted Charlie Mansueto at the Behavior Therapy Center of Greater Washington once I graduated and started that fellowship there. So I think there are lots and lots of opportunities. And I think the population that treats anxiety and related disorders, one of the things that I've noticed since day one is that I think because our population is such a great people to work with, usually above average intelligence, and have great imagination, lots of great personality, caring people, and we see them get better. So I think maybe that's the reason there's less burnout, but most of the clinicians, even the big experts that have been doing this for 30, 40 years, always very enthusiastic and wanting to help. So I think that was one of the things that I learned, is you can always go talk to someone, and that you need to specialize. Specializing is crucial. So that was the most valuable lesson, I think, that I learned. Did I cover that?
Thank you, Andrea. Denise, would you like to add on?
Sure. I think when you're in grad school, it might be a little bit harder to find training opportunities. I think, again, the practicum and the internship is a great opportunity to get clinical experience treating the population that you're interested in. I also think like nowadays, when I was in the 1990s, when I was in grad school, it was harder to find, but it's a little bit easier to find now. If you're interested in specializing in OCD, there are IOCDF affiliates all across the country, many of whom run monthly lecture series. You could go to those. The IOCDF conference, again, is wonderful. There's a clinician track that people can go to. That's something you could do if you're in grad school and then if you're out of grad school. When you are, like Andrea was sort of saying, like there are many different, like again, if you're interested in treating OCD, there's OCD specific treatment programs throughout the country. So in Massachusetts, there's one for adults and there's one for teens. And so people who are interested in like learning about the disorder or learning about the treatment sometimes volunteer in these programs, or they get their first job as a counselor in these programs. Post-grad, if you're waiting for the 2 years to get licensed, you can work in one of these jobs and get supervision and clinical experience. Like Andrea said, volunteering at any of these conferences. ADAA has a wonderful annual conference. Most of you guys probably already know that. IOCDF also has a wonderful conference. ABCT does. So kind of going to these places, hearing these lectures and meeting people that might be your mentors someday, because I think all of us mentor lots of people. I work with lots of grad students, post-grad students, and supervising them. Helping them just sort of figure out where their opportunities might be in their local community. So if you kind of go to these conferences and meet people, we tend to be very open, and we really like what we do, and we really want to help the populations that we're serving, and we want to bring good people in to be our own peers. And so, like I said, we do a lot of mentoring, not just post-grad, but during grad school too. So kind of go to ABCT, ADAA, IOCDF, and see what's going on in your local communities and see what you can get involved in terms of just community resources, these annual conferences, or meeting people and ask for mentorship opportunities. That's what I would do.
Yeah, I agree with everything that's been said. The only thing I can think to add is something that was valuable for me in terms of really thinking of myself as specializing was consistently interacting with the population that I want to treat. So, something like going to a conference and seeing a panel of clinicians speak, that's a great way to get trained. One other way to get trained is to, in addition to that, is to write. So I got very involved in sort of blogging and just putting stuff out there that I thought sounded pretty good, and opening up dialogue with people who could then write to me and say, oh, I really relate to this thing that you wrote about this aspect of anxiety. Here's how I experience it. What do you think about that? Mm-hmm. And what I found from spending a fair amount of time reading, thousands upon thousands of people telling me their stories, is that it teaches you how to pick out the patterns. It teaches you how to understand how people with these disorders actually think, which is a huge asset as a clinician. So that's been really important for me in terms of taking opportunities to be more specialized. There's sort of the academic learning, and then there's the, getting in the heads of people who are in this population that you want to treat. And so online interactions has been one way that I've been able to do that. Yeah. And in terms of other valuable lessons, it's just been, I can't speak for every graduate program, but the impression I got from my graduate program is they don't care that you're interested in being a specialist. I mean, it's nothing against them. I mean, their job is to teach you as much as they can and provide you with all the necessary skill set for becoming a therapist, not the specific therapist that you want to be. So you have to be the one to push for it. You have to be the one to ask the questions and reach out and make the connections and make it happen for yourself. Don't expect somebody else to come in and say, oh, you want to specialize in this? Here's the books to read, here's the courses to take. You actually have to do that work on your own.
Especially if you go to a master's level program that's not like CBT oriented. They're going to teach you everything, and then you have to go like John did and sort of make that CBT or OCD specific. But I also wanted to back up what John said about sort of getting involved in the population that you want to treat. That is also something I did. I ran a lot of support groups. I started a couple of different monthly lecture series in my local community where we were having people come and give an hour-long talk, and then we all sat together after and processed. And like you said, in terms of just pattern recognition, this is an extremely important thing to sort of do. And a lot of that just becomes like your own initiative. What do you want to do? What kind of opportunities are you going to create for yourself? And I think that if there are people who are very entrepreneurial or, very advantageous, I think that there's lots of opportunities for you.
Thank you so much to the three of you. I think we're going to move. We're going to move on to questions. Okay. Specialization. Going to look more as a generalist. What are the drawbacks of yourself as being capable of treating too many conditions? John, if you could start, followed by Andrea.
Is everybody else hearing this echo?
Yes, it's breaking up.
It just suddenly started. Okay, I think it's gone. Okay, so the drawbacks of marketing yourself as a specialist is that people are, is marketing yourself as capable of treating too many conditions or every condition, as opposed to being a specialist, is that people are coming to you for help with their problems, and it's very important to them that they feel understood. And by and large, people who are willing to do the courageous thing and actually ask for help for mental health issues are pretty smart, and they can tell when they're being condescended to and patronized. They can tell when they're being lied to. And so when you look at a list of things that a person treats, and it's every mental health issue under the sun, they know that it takes time and energy and effort to actually be really skilled at treating any individual thing. So if it's too many things, then obviously you either aren't very skilled in any of them, or you are skilled in some of them and you're just lying about the others. And I think that your future customers, your clients they're going to be able to pick up on that. So it's just poor marketing to spread yourself that wide. Focus on a couple of things that you really are confident in your competence, and then you can back up why you should be confident in that. Yeah, I think that's pretty much my take on that.
I agree. Exactly. A lot of times, except for sometimes, patients will not understand that therapists because they don't know our field, and they won't understand that we can't be good at treating everything. I always compare it to like a general practitioner. If you go to your doctor and you have cancer, he's going to be able to recognize it, but he's going to send you to an oncologist. He is not going to, would you trust him to treat you for cancer and make sure that you got better? So probably not. And if you're going to deliver a baby, he's going to send you to not an oncologist, I hope, OBGYN.
Yeah.
So they know how to deliver a baby, but that's not their area of expertise. If there's complications, they specialize in diagnosing and knowing when to refer. So if I'm not good at, I refer out for grief, for couples, for families, for eating disorders, because I know my area really well. I believe it's, kind of false advertising, but I see it all the time. Patients come in, or if you look on Psychology Today, you see, 5, 6, 7 different theoretical orientations. You see that they treat everything under the sun, but then it says, I specialize in anxiety. And I don't believe that can be the case. There aren't enough hours in the day to know how to treat anxiety and treat it well, and to know all the subtle intricacies of the anxiety and related disorders. That's a lot to know, and I believe, as John said, that we have a duty to know it well, because people are coming to us in the depths of despair and they're trusting us, and our job is to help them get better. It's the same, to me, in my opinion, it's the same as when you go to your doctor. They need to know when to refer to make sure that you get the best possible care. It's no different in mental health. So I thoroughly agree. And again, in my opinion, it borders on being unethical, because we have a duty, once we get licensed, to do what's in the best interest of our patient. And how can you know how to treat everything well?
Yeah, so I think if you're marketing your practice and you market yourself as being capable of treating so many different things, I think if you have an educated consumer, they're probably going to bypass you and go to somebody else. And if you're treating someone with anxiety, OCD, or depression, there is evidence-based treatment for what you should be doing, and most people who specialize in these 3 disorders spend a lot of time educating themselves in all the ways that we've talked about already on how to do this in a very sophisticated, nuanced way. And again, if you have an educated consumer and they're looking for a specialist or an expert, they'll probably bypass you and go on to somebody else.
Thank you so much, Denise, Andrea, and John. Let us move on to the next question. What typically happens when you see a patient who was previously treated by a generalist? Denise, John, and Andrea, if you could comment for 2-3 minutes on this. Thank you.
Sure. So in my clinical experience, if someone's coming to see me after they've seen a generalist, it's often because their last attempt at treatment wasn't successful or wasn't as successful as they'd hoped, and they were looking to try it another time or in another way. And I think one of the reasons why it may not have worked is because the generalist didn't know enough about OCD or about OCD treatment, and despite best efforts on both parties, things just didn't really work out as they'd hoped. And so when I'm sitting with someone who's come to me because of that situation, and we can actually talk about OCD in a pretty detailed way, and like we've all said, because we have this pattern recognition, because we've treated hundreds of people, we can almost predict the ways in which OCD has manifested itself in people's lives, the consequences of having it, the family dynamics, the issues related to school or work. People oftentimes are very relieved. A lot of times people with OCD or anxiety are sort of embarrassed or ashamed about their symptoms, and when you can sort of ask them specific questions, they feel like they didn't have to bring it up. They're more willing to actually share some of these experiences with you. And if you can talk about treatment, which, you know, for these disorders is oftentimes, you know, confronting discomfort or things that people fear. People sometimes dread doing the treatment. If you can talk about it in a very confident way and really walk someone through about what will be happening for them and how much better they will feel and at what points, they tend to be, although a little bit worried about doing the treatment, a little bit more motivated and hopeful. So in general, I find people to be pretty relieved when they find a specialist, and oftentimes they walk out of that first meeting or two feeling pretty motivated and hopeful about their future. That's what's happened in my clinical experience when I've inherited a case from someone who's a generalist and who the treatment hasn't gone quite so well.
Yeah, I would agree with that. And I would just add that it really depends on whether we're talking about a generalist who's generally very good or a generalist who's generally very sort of okay or maybe not so good. So if somebody's coming to me having seen a generalist and they were given poor advice for how to treat their OCD, then, you know, they're coming to me already very skeptical, already very afraid, and of course very relieved when I'm able to sort of psychoeducate them on what their condition is and how it's treated. Under better circumstances, I get referrals from generalists or specialists in other areas of psychology, like trauma or something like that, where the work has been going okay, but it's plateaued. There's still something getting in the way, and the generalist, the other therapist, is able to recognize, well, I think the issue here is that there's OCD, and the OCD isn't being treated, and I'm not really trained in treating OCD. So then that generalist is going to refer their client to me, and that client is arriving with good feelings about the generalist and sort of excited about the idea that, okay, it's not my fault that treatment kind of stalled, and it's also not my therapist's fault. And it's not my fault for figuring out why my therapist, not figuring out why my therapist wasn't able to pull it off. It's that there's this other thing, and now I can get to work on this other thing. And then I'm able to work collaboratively with that other therapist when needed. Those are the cases I really enjoy.
Yeah, that's an ideal situation. That happens on occasion where you get someone who's been treated by a generalist, and the generalist realizes that this is beyond my area of expertise, and then they said, let me find an OCD or anxiety expert specifically for you. That's great when that happens, and it does happen. A lot of times, you know, unfortunately though, we do see people who come in and they have worked, they'll be very skeptical and say, you know, what's different about you? Even though they looked us up and contacted us, they'll say, why are you different? I've been in therapy forever and nothing's ever worked. You know, it's been a waste of time and I don't have any hope. I'm never going to get better. I've tried CBT, I've tried this. And then when I start to talk to them in further detail, it turns out that they really didn't have a course of cognitive behavioral therapy. They, you know, they aren't familiar with a lot of the terminology. They haven't done the cognitive restructuring or behavioral component, any exposure work. So then once I explain that, they hear it, and then you talk more to them, you see a lot of hope develop. Typically, it's what I like to see, and it happens more often than not. So, yeah.
Thank you very much.
Can I just note one thing? I just want to note one thing. People with anxiety and OCD oftentimes talk as a way of avoiding having to deal with some of the very difficult things. And when they go to a traditional psychotherapy with a great therapist who's doing really good psychotherapy, they both might get a little bit frustrated. Like, we're doing really hard work, the person's showing up, they're engaged, but like nothing's getting better. And it will really take an anxiety disorder or OCD specialist to say, like, yeah, you guys are great people trying very hard, but you're kind of avoiding the very things you need to do in order to get better. And that's something that an expert or a specialist would be able to determine. And so I think it sort of like reinforces everything that we've said up to this point.
Thank you for adding
And
on.
unfortunately,
To question 5, to qualify as an expert, does a clinician need to follow evidence-based treatment protocols if the theoretical orientation doesn't fit them? We'll start with this big question with Andrea, followed by Denise and John.
absolutely, yes. That is key. As I said earlier, once we become licensed and we're responsible for the well-being of our patients and, causing no harm and making sure that they get the best possible treatment, that we need to learn what those treatments are, what evidence says is the best treatment and most effective treatment. And again, in my opinion, it's negligent and unethical to not learn that and to not at least make your patient aware and say, I'm not a CBT therapist, but research shows this is the most effective treatment. If you're willing, you can try my approach, which is something else, whatever that may be. But the research shows that it is the most effective, so why wouldn't you offer it? And a lot of times new clinicians, I think, will come in with the session feeling, well, I know this exercise really well, so I'm going to use this, or I know some of these techniques, I'm going to use that because it makes me comfortable. And again, that's unethical. It's unethical to impose a treatment protocol on a patient. We don't mold our approach to the patient. We learn about the patient, and then we don't impose our treatment on them. We find what works for them following evidence-based treatment protocols, but sometimes we need to add another CBT approach, such as maybe acceptance and commitment therapy, some techniques for that. If the patient's struggling with motivation, or if that's an approach that works better for them, if they respond well to that. I often incorporate some motivational interviewing techniques, sometimes some emotion regulation and stress tolerance, but they are evidence-based treatment protocols, and I use them for what they're supposed to be utilized for. So, in that sense, there are a lot of options and there are a lot of ways to get to your patient, but you need to know your patient and what works best for them, and you have to follow an evidence-based treatment protocol. It's the same thing with the doctor. Again, if you go to a doctor and would you go to a doctor if you had high blood pressure and high cholesterol, and he just said, I'm going to try this approach. There's an evidence-based treatment protocol out there for that, but I'm not going to use it. I'm just going to use something that I'm comfortable with or that I thought of. So that's my philosophy. And I think it's just very important to learn the evidence-based treatment protocols and learn them very well.
Thank you, Andrea. Denise, John?
Yeah. So I believe that to qualify as an expert, a clinician does need to follow evidence-based treatment protocols, regardless of whether or not it fits their personality or the way that they like to do things. I think that being an expert implies that you have comprehensive knowledge on a specific subject, and if you aren't doing the treatment that the research says is the most effective, then I don't think you're an expert.
I agree with everything that's been said. I would just add that this word fit might be a little problematic because it sounds restrictive. Following evidence-based treatment protocols doesn't mean that you're not allowed to be creative.
Right.
This sort of evidence-based, this term comes, I think, with this negative connotation that it's everything you do, you have to be able to cite the research study that demonstrated why you did it. And I don't think it's about that. Exposure and response prevention, all of the evidence is there. That is the best treatment for OCD. This is not something worth debating. But within exposure and response prevention, you have to be creative. You have to do things like jump around the hierarchy and approach things from different angles in order for it to work. And you don't always have time to run a study on it. So, you might come up with an intervention that is wholly your own, And the question you want to ask is, why did I come up with that? And if you could say, well, because the evidence of my experience in doing this evidence-based treatment is that this is the kind of thing that works for this client, then, sometimes you just need to throw a pillow at somebody or spray them with something. It's just, it's not, to say that I'm fitting into an evidence-based protocol doesn't mean that I'm squeezing into some box that's not flexible at all. It means I'm using a knowledge base that's on the platform of a lot of work that a lot of other people have done and demonstrated to be effective.
Yeah, and to do it well, you are using all of your other therapy skills, right? You're building a relationship, which is always the most important clinical intervention you're using, regardless of what your theoretical orientation is. You're working on motivation. You're helping process the loss of time. You're working with families, you're working with schools, you're helping build, relapse prevention. So to be a good evidence-based clinician does not mean, like John said, it's manualized or you're fit into this little box. It's like you're using all of your other therapy skills, but using them all in the context of what we know works based on mounds and mounds of research.
And that's what I was saying with, sometimes we'll throw in some other theoretical orientations, but they're known to accomplish the goals. They are evidence-based protocols as well, but you're still able to be creative and figure out what works best for your patient.
Well, there's a lot of evidence that the patient won't do the work if they don't trust you, right?
Thank you
and
so
there's
much.
no research project that says how to get somebody to trust you.
Let us move on to question 6, as we will still have a Q&A at the end, and we have several participants who have sent in questions. What personal attributes do you think help when specializing in anxiety, depression, and related disorders? John, you were saying something, so we'll have John and Andrea and Denise, please.
I don't know that there's that it's all that different from working in any other area of psychology. Empathy is essential. Compassion is essential. Some level of confidence in your skills is essential. I think what might be more specific, at least to OCD anyway, is the ability to remain unimpressed when somebody tells you that they have some thought that you think you've never heard before. It just means you haven't heard that content before. But everybody with OCD is at some level of afraid of losing their identity, and they just come up with new and exciting ways of expressing that. And so the ability to be yourself in the room, but also step aside from some of your initial reactions, like, whoa, and actually be able to reflect back to the person, okay, well, that's an idea, and let's get to work on it, and not be so consumed by your initial shock by something that somebody might tell you or what it might mean to you. But I think that these are probably skills that are necessary in any form of psychology.
It might be the thing that might be a little bit different with the problems that we're treating is that we're going out with patients and we're doing exposures, and we need to be able to do the same exposures that we're asking the patient to do. So if I'm afraid of heights, I need to be able to do whatever the patient needs me to do. We need to be willing to do whatever it takes for our patient. And some of the exposures that we do, you may not be, a lot of people may not be comfortable with. So we have to be willing to get our hands dirty, whether that means doing exposures to things, contaminants or with OCD, or things that we're uncomfortable touching, bodily fluids, things like that. So you might not see that in, grief counseling or other areas. We're doing a lot of work with vomit and icky things. So, or scary things, So I think it's just really, also hoarding. So hoarding disorder, some of those homes are dirty, some aren't, but some we need to be able to go in there non-judgmentally and, as John said, empathetically understand that patient and be able to help them. And I think another attribute is, to have a strong passion to want to work with this population, which again is probably, as John said, no different than any other area.
Yeah. So I'll just pick up on something that Andrea was saying. I think so exposure and response prevention is the first line treatment for people, with OCD, and not all clinicians are cut out to be ERP therapists, to be perfectly honest with you. I've trained over the last 20 years, trained a lot of people in ERP, and many people might be interested and very engaged in the training, but very reluctant to go to become an ERP therapist in the real clinical world. And that's in part because of what Andrea said, sometimes you have to be in the dirty bathroom, touching the toilet seat with people, or even if you're okay with doing that stuff on your own, you really do need to be comfortable sitting in the face of high anxiety or distress a lot. And so not, you know, many times people aren't able to do that, or you have to really be able to tolerate your own level of distress and uncertainty when you're doing these things. I mean, this would be your job, right? So because you don't always know how the ERPs are going to turn out. Some of them are just sort of behavioral experiments. Like you design them the best you can, you understand you're going in, you're not sure, you're going to collect data. And so to really sit with that high level of distress as often as you might need to if you're an ERP therapist, or to sit with that high level of uncertainty, isn't always what people want to do or are able to do themselves. So I think that that's the only thing that I would sort of elaborate on based on what both these guys said.
Thank you very much to the three of you. Now let's go back a little bit in time. How long did it take you to feel like you had actually become an expert? Denise, if you want to start, John and Andrea.
Sure. So I finished my graduate program in 1996 and then helped to open up the OCD Institute at McLean in 1997 and helped to run that for 10 years. And I would say probably at the 5-year mark, I've sort of felt like, okay, I really kind of know what I'm doing here. I feel comfortable in recognizing what OCD is, treatment planning, running good ERPs, running groups, sitting with families. But even though I felt you know, pretty confident in my knowledge base at the 5-year mark, it's interesting because I didn't leave for another 5 years and start my own practice. So I think at the latter half of me working at the OCD Institute, I was really practicing sort of my own independence, doing treatment planning on my own, running ERPs on my own, doing program development on my own, supervising people on how to do it. And it was really at, you know, the 5-year mark felt critical to me, and then the 10-year mark felt really critical. But even though I do, you know, local, national, international trainings on how to treat people with OCD, I still feel like I'm learning because there's a lot that's all happening, right? So we're talking about how to integrate acceptance and commitment therapy into how to do this, how, you know, there's all new evidence that's sort of supporting how you can enhance your ERP. So even though I consider myself an expert and have seen like probably 1,000 cases of people with OCD, I still go to the conferences, I still sit in the research symposiums, I still sit in the clinician presentations because I want to learn from what other people are doing in their experience. So while I feel like I'm an expert, I'm still really learning.
How long did it take me to feel like an expert? Well, you know, day one, but I was wrong. So, you know, I don't know. I mean, this is a hard question for me to answer. I don't actually think of myself as an expert. I rely on other people to tell me that I'm an expert. I mean, it's not to say that I'm not aware of the work that I put in and the books that I've written and things like that, but it's really, you know, people call me an expert. I mean, people also call me doctor, and that's also not true. So I try not to, you know, get too caught up in the labels of things. And I just keep asking myself, you know, am I doing my due diligence? Am I just sort of piggybacking on what Denise was saying? You know, am I still learning? That's actually a better sign that I'm an expert than that I've decided I know it all, which would imply that I actually don't know what I'm talking about.
Andrea?
I agree with everything that's been said. And, you know, if I think about it in terms of years, I'm probably right on target with Denise. I think, you know, there's always that element of when you're first starting, that imposter syndrome, and this person's trusting me, and I don't really have any idea what I'm doing, but you have supervisors, and that everybody starts there. And hopefully you do feel that way. That's a good sign. I think it takes, I would say, you know, several years before feeling that kind of completely wear off and feel motivated, you know, that confident, like I really want to help this person. I can, you know, I feel as though I can help this person. But that being said, I do think I'm consider always a work in progress, and I am the same as we attend the same conferences and sit in on the clinician conferences, the research material, because we want to keep up with the latest and cutting edge protocols and techniques. So I always, when I supervise people and train people as well, I say, you know, it's always a work in progress, and never stop going to case consultations. Once you have, you know, your full license, you don't technically need supervision, but I recommend going to, I go to case consultations once a month with 4 psychologists, colleagues of mine, and it's, invaluable. So never stop learning.
Thank you. Now we're going to have our last panel question before we answer the Q&A. What do you know now, 10 or more years into your career, that you wished you had known at the beginning of your career? A bit back to lessons learned. Andrea, if you want to go on, followed by Denise and John.
I think that the most important thing is to know that it is okay to make mistakes. It's not okay to be negligent. But if you're trying your best and you're consulting and you have a supervisor and you're doing everything you can to learn about your patient, and I always tell the people that I train, know your patient well. I do a 2-hour evaluation and I know a lot about them from the very beginning. And then I watch them and I observe them and I pick up on subtle nuances about that patient. And, but we're human and we can make mistakes. And sometimes it just means that we need to modify treatment or go in a different direction or utilize, like we were saying before, another treatment approach. But that comes, I think, with a lot of experience as well, knowing when to incorporate that. But that, I think, to know that that's okay, as long as you're consulting and you're, learning and reading material and not just seeing your patient we have a session and talking to your patient and they walk out. It's like we spend a lot of time preparing for our sessions and reading about our patients. That's one of the big differences from sometimes generalists will see patients back to back all day. Well, we are spending a lot of time learning about our patient, collaborating with their psychiatrist, their family, their loved ones. So as long as you're doing everything that you can, it is okay to make mistakes. And you're not going to, I think Charlie Mansueto said this to me one time, you're not going to break someone. I don't know if that's true. I hope it's true. But so far, I don't think I've broken anyone. And I think that's something valuable to learn too.
Yeah. I think there are a couple of things I'd like to pass on. I think the first, regardless of what your theoretical orientation is, regardless of what you're specializing in or not, if you're generalizing, I think it always comes back to the relationship and to take the time that you need to develop that relationship. I know sometimes when I'm training people to do ERP or CBT, because there's a lot of steps that people need to take or a lot of different treatment planning things you want to help people go through, they feel rushed to get to that treatment planning part instead of taking the time that they need to develop the relationship, because like we've all said up to this point, like no one's going to do anything with you unless they trust you and like you and believe that you really, can take care of them when things get really hairy. So I think taking the time to really build that relationship and that relationship is super important. I think when I first started, I preached self-care, but I think it wasn't until I got a little bit older when I actually started to live self-care. We're giving out every single appointment that we have. It doesn't matter where we work. Every clinical interaction that we have, we're giving of ourselves. And I know that most of us that do this passionately receive energy back from that, but still we have to make sure that we've taken care of ourselves in order to continue to be able to do this work long term. I also want to say that I think, like Andrea said, don't ever be afraid of admitting what you don't know and getting clinical case consultation. You're not a fraud. You're actually doing what you need to do. Wherever you can get that case consultation, go for help. Never feel like you have to go it alone. And then last but not least, treatment teams are a wonderful way to work, especially if you're working with someone who's really, severely anxious or depressed or has really bad OCD, because a lot of times you have to split up the work between a psychiatrist, a therapist, a family therapist, and then the ERP therapist. And so never really feel like you have to take it all on your own. Like really do consider building a treatment team. I have had some wonderful successes with some pretty hard cases doing that.
Yes, absolutely.
Yeah, I would say, I'm really happy doing what I do. So I don't know that what I know now that I would want to have known it then, because what I know now is based on what I didn't know then, which all the mistakes that I made up to this point. So I wouldn't want to go back in time and not make those mistakes because I wouldn't end up back here. I think in addition to everything that's been said, I totally agree with. I think just on the self-care front, understanding that if you are happy with what you do as a specialist, You need to understand that if you don't make the conscious choice not to work, you might just work forever all the time, and that's not good for your health. That's not good for your relationships, and ultimately it comes back around and ends up not being good for you as a clinician because you start to fall apart at the seams. You need to know yourself well enough to know when it's time to stop, and you need to actually tell yourself to stop and not expect that, oh, I'm going to stop later, or things are going to calm down later. I'm going to just finish this one more thing, and then I'm going to take that break. I'm just going to get caught up on these emails, and then and then I'll enjoy my lunch. You have to actually put some effort into it.
Thank you so much, Andrea, Denise, and John, for answering all these questions. We're now going to begin answering some of the questions that were submitted during the presentation. You can still, participants, submit questions in the chat panel. Andrea, Denise, and John, I think let us do 2 questions as we have still a couple of minutes. Please comment on this, how you feel about it. Will specializing affect my business ability to get patients? What is your experience with this?
I think it will help your ability to get patients.
Yeah, I mean, I think it depends on what you're specializing in. If you're choosing to specialize in anxiety, OCD, or depression, I think that there are many people out there who are struggling with these 3 problems. And if you are a specialist and you build a reputation for, doing a good job, you will be inundated with people. Like John said, I mean, we can all work until we drop. I mean, I have more people, referrals than I know what to do with. I run a wait list. That's why I'm really working hard to train other people so that they can pick up some of these cases. So I don't think being an evidence-based therapist in any of these 3 disorders is going to hurt your practice. I think you're going to have a thriving practice.
Yeah, I wouldn't make your specialization so narrow that you're only going to be treating, one aspect of anxiety or OCD, for example. There may be a call for something like an emetophobia specialist or something like that. I mean, those do exist. I think that probably wouldn't be so much fun to only work on the same fear over and over again, just from my personal perspective. But it could also be limiting from a marketing perspective. If you could broaden it to something like a diagnosis of, OCD or anxiety, then that's actually, you need to have that fit, because you're selling a product at some point. Your website is saying, we do this, and people need to be able to see that and be like, oh, that's what I'm looking for. If it's too broad, it's like, it's like going to a restaurant that has a buffet and they have every possible kind of food. People don't tend to eat the seafood at those places for good reason. And if it's, too narrow, then it's like, oh, no, that's not for me. I'll go on to the next one.
Yeah. The other thing I want to just note one thing that I think is really important. If you are a specialist, you can then you can do other things like lecture and teach and publish and do research and publications, trainings locally, nationally, internationally. So it's not like you're just doing clinical work. As an expert, as a specialist, you're sort of opening yourself up to be doing a lot of other things. I mean, we've all done a bunch of different things in our careers as a result of our specialty.
Absolutely. And the other thing too is that what John was saying, if you are like an emetophobia specialist, you still, I don't know that there anyone that does that, but if you treat OCD, you have to know how to treat the other anxiety disorders because the comorbidity is so high. They tend to overlap and bounce around. And so you need to know the difference between social anxiety. You need to know the difference between panic disorder and someone panicking in response to an OCD fear. So, and the anxiety disorder is a really broad anxiety and related disorders, the OC spectrum disorders. It's a broad group of disorders. So people will frequently say to me, isn't that boring? It's quite the contrary.
Yeah, because you end up if you work with kids with anxiety or OCD or depression, you're also working with the families. You're also working with the schools. So you're developing these subspecialties just by way of your own clinical experience.
Thank you so much, Andrea, Denise, and John, for your presentation. And thank you also to the early career professional and student SIGs, especially Stephanie Woodrow, for the facilitation work with our speakers. And thank you also to the participants for attending today's webinar. You will receive a follow-up email within an hour that includes a link to the evaluation and a link to the recording of the webinar. If you are an ADA member since 3 years, speaking of specialization, and a clinician with over 5 years of experience since graduation, consider applying to ADA's Clinical Fellows Program. This program gives you a specialization in anxiety, depression, and related disorders through ADA's continuous education programs year-long. In addition, you will receive a special designation in the ADA Find a Therapist online directory, recognition on the AA website, and a clinical fellow certificate. And if you are not yet an ADA member, please consider becoming one. ADA offers an excellent members package, such as year-long access to continuing education, free access to special interest groups, including peer online consultation groups, significant discount to ADA's annual 4-day conference, promotion of your practice in ADA's online Find a Therapist database, and much more. We hope you will join us at the Anxiety and Depression Conference 2019 from March 27th to 31st in Chicago. And on behalf of ADA and our presenters and our SIG, thank you for joining us today and have a great rest of your day.